Hello, my name is Monica Tennant, and I'm a clinical nurse specialist with over 23 years of experience in both acute and critical care nursing. I'm going to review the Clinical Institute for Withdrawal of Alcohol Assessment Protocol, also known as CIWA, today. So with CIWA, what we have is alcoholism as a disease. And just like we treat any other disease, we should treat alcoholism as the same. So the purpose is really to assist with the early identification and management of those patients who are at risk for alcohol withdrawal syndrome. Any healthcare facility undergoing a regular scheduled surgery, procedure, or routine nursing care, a lot of the times our patients actually won't tell us whether or not alcohol has been a problem for them because they think it's just routine, especially for outpatient surgeries. They don't think they're actually going to be here long enough for the withdrawal symptoms to be any problem. We really want to prevent some negative physical and or psychosocial consequences of the withdrawal experience, because what we know is that the longer a patient is going through delirium tremens or some of the side effects of alcohol withdrawal, the more permanent the damage can become. So we want to improve those discharge practices and really promote some positive outcomes for these patients. Now, the current hospital policy is that we are not an addiction treatment center. We do not provide those services that are truly required for the licensing and the permits to actually do alcohol withdrawal and addiction treatment. So we're just going to treat the symptoms of the withdrawal. We're going to manage those physical assessment and psychosocial assessment symptoms. But we're not going to truly do an addiction or an active withdrawal program, because those can actually go over weeks and or months. We're going to advocate for the patient's decision, and if our patient's decision maybe differs from our own personal decision, we are patient advocates and we will support that patient's decisions. Of course, give them all the resources that they need, but you are a patient advocate. And if the patient says that they are not going to quit drinking, you are going to support that, and you are going to manage their withdrawal symptoms during the hospital stay and not judge them. So alcohol in the brain. Alcohol acts like GABA in the brain. And in this situation, the GABA is inhibitory. So for a non-alcoholic patient, what you can see on our slides over here is that GABA is on one side and glutamate is on the other. Glutamate is an excitatory neurotransmitter. For non-alcoholic, you've really maintained sort of an equilibrium here. And what we would like to do is treat that just as any other type of withdrawal. So if we have a potassium replacement protocol or we have any other sorts of replacement protocols, we would actually supplement with what is in deficit. So for this situation, the occasional user might have a little bit more alcohol intake than normal. So that alcohol weighs upon the GABA that the body already produces. And so you can see on the scale, you've got the GABA plus the alcohol giving more inhibition of the central nervous system. So with this one, you're usually seeing slowing of the nerve systems, like slowing of the reaction times. A lot of people get sleepy or somnolent. And so with this occasional use, I mean, it's less glutamate to balance the excitatory versus the inhibitory, but the occasional use is intermittent. And when that use is stopped, they'll actually go back up to the non-alcoholic or the homeostasis aspect to it, and the scales will be balanced out. Now, once it's chronic, the body has equalized with the consistent alcohol intake. So the GABA plus the alcohol is on one side of the scale, and then the glutamate actually has to be upregulated because you've got two things on one side of the scale, the GABA and the alcohol. So the glutamate has to work a little bit harder, and the body has to produce more of that. So unfortunately, when those patients are suddenly withdrawn from their alcohol, on the bottom, you can say that there's less alcohol and GABA on the left-hand side to balance that excitatory versus the inhibitory state. So you've got upregulated glutamate Remember, that one's excitatory. So you've got all those CNS symptoms of excitatory: cursing, aggression, restlessness, climbing over the bed rails, and all the physical assessment that we're going to go over. So identifying patients at risk for alcohol withdrawal. On the intake, when the patient is actually admitted, we want to know if there's a severe history of alcohol dependence. Most importantly with these patients, have they had a history of withdrawal with seizures or delirium tremens? That makes them at a significant increase for the withdrawal side effects. Have they increased the duration or the amount of their drinking? Are they a binge pattern drinker? Multiple past detoxifications or multiple past admissions for detoxifying or into an alcohol or drug treatment program. So you assess those on admission history and then the patient intake form in our current electronic medical record. In the first wave, initially the symptoms that they're going to go through in 6 hours of the last drink, and they peak in about 24 hours, include just a mild excitation. So they have mild tremors when they hold their hands out, maybe some mild diaphoresis, some sweaty, nausea, anxiety, rapid heart rate, and a little bit of an increased blood pressure. However, the second cluster of the symptoms commonly occurs within 12 to 48 hours of the abstinence, and then they include excessive neuronal excitation. So those mild tremors have progressed to gross tremors. The mild tremors, you may actually have to hold their hand for it to feel the tremor, whereas on the gross tremors, you don't even need to hold their hand. They just hold their hands out and you can very easily see their tremors. Their anxiety has increased, they're agitated, they can't sleep, they can't eat, they have maybe some weakness. There's disorientation, and it could be in any aspect of the orientation: person, place, time, as well as situation. This is when the visual and the auditory hallucinations begin. The headaches are moderate at this point in time, but they really quickly progress to like a squeezing headache or a full feeling. And they may include seizure activities of the tonic-clonic type. And they have a brief post-ictal period, but then they go right back into this excessive neuronal excitation. The third set are really unfortunate because we have a mortality rate of over 15% with delirium tremens. It's about 5 to 10% of alcohol withdrawal patients, and it's about 48 to 96 hours after they stop their last drink. So the symptoms are continuous auditory and visual hallucinations that don't stop. It's continual. They have tactile disturbances. They feel pins and needles. They're itching. And you want to find out if they're itching because they have a history of psoriasis or eczema, or whether or not this itching is new. Confusion, disorientation, clouding of the consciousness, impaired attention. They'll start to tell you a story and then get sidetracked and totally inattention to what you're trying to teach them or what they're trying to do. They have pronounced autonomic hyperactivity with these patients. So if left untreated, the mortality rate's over 15%, but it drops to 1% if we have swift and adequate treatment. So this is the CIWA assessment. It is found in our electronic medical record, and it's easier if you just print the entire thing out so that when you go into the patient's rooms, you can ask the questions and actually circle which one they're at on here. So this is what it looks like. There will be drop-down boxes for you, but as you can see, they only show up, for instance, when we look at nausea and vomiting scale, it really tells you 0 is none, 1 is mild, and then 3 is the midline where you have intermittent nausea. So it's really going to be your critical thinking for the first 4 things as far as whether or not they're between a mild or an intermittent nausea, or whether or not intermittent or constant nausea with the dry heaves and the vomiting. That goes through tremors, anxiety, agitation, and paroxysmal sweats. The entire thing will actually be totaled up on your CIWA score at the bottom. And then your scores determine the severity of the alcohol withdrawal. A score of 0 to 7 is minimum to mild withdrawal, and it usually doesn't need any type of a treatment, but you do have to make sure that you're reassessing your patient per the protocol. Because remember, some of these don't peak until 24 or 48 hours after the patient's last drink. And note, that patient's last drink may have actually been in their car when they were dropped off at the hospital. A score of 8 to 16 is moderate withdrawal. You're going to need a little bit closer monitoring required, so the frequency of your assessments will be a little bit faster, as well as treatment with your benzodiazepine. The score of greater than 17 is severe withdrawal. It typically has monitoring greater than every 30 minutes, and it's preferable to be in the ICU for this situation, because a lot of these patients with severe withdrawal may actually need a continuous infusion of the benzodiazepines. So the treatment goals are not to knock the patient out. The treatment goals are to keep the patient awake, calm, and cooperative. Remember, this patient has to answer questions through the CIWA scoring tool. And if your patient can't answer questions for the tool, you can't appropriately score them, nor should you. So our goal is reduce the symptom severity, prevent any major complications such as the seizures or coding, reduce long-term central nervous system complications. Remember, the longer these patients are having these problems and side effects, the more problematic it will be as far as long-term complications. You want to decrease any risk to having a level of consciousness where the patients can't be interactive with your CIWA scoring, because if they're unable to report those auditory or visual hallucinations or that headache, you're going to underscore them, and unfortunately, they're not getting treated appropriately. Pharmacologic therapy. Benzodiazepines are the gold standard for alcohol withdrawal. They replace that inhibitory effect that we saw on our scales on previous slides when that alcohol has been discontinued. They have proven efficacy in reducing the incidence and the severity of the complications, such as seizures and delirium tremens. Ativan is great because it has an immediate onset, and the half-life's 10 to 20 hours. We also prefer it in the elderly and or moderate to severe liver dysfunction patients. It's available in all routes, oral, intravenous, and intramuscular, and that way, if you have a really acute situation, you can give your patient Ativan even if they're running down the hallways. However, chlorodiazepoxide, which is Librium, that's intermediate onset. So it's not going to take effect as quickly. It does have a longer half-life of up to 30 hours, but it's only available in oral dose. So this one is usually used in the outpatient setting because it provides a smoother taper and it contains some active metabolites. So we really don't use Librium too often in the acute care setting. I'm going to be using lorazepam or Ativan a lot more frequently. So here's your scores, the dose, and your reassessment. If your score is 0 to 7, remember that's mild. There's almost nothing that you're going to see too much on these patients. So you're not going to have to give any lorazepam. But what about 2 hours from now? You want to go back in there and reassess them using the same CIWA-Ar scoring tool. Let's say you go in 2 hours later and they're between 8 and 10. In this situation, they've gone to some moderate symptoms, and your assessment will show you that you're going to need about 1 milligram of lorazepam, and the doctor will tell you if it's lorazepam or whether or not it's the Librium, which would be the 25 milligrams PO. But 9 times out of 10, you're going to be giving 1 milligram of lorazepam. Then you're going to go back in there in an hour. Just as though we were doing any sort of a pain medication, we always go back and we reassess our patient an hour later. So in this situation, you're going to go give your lorazepam and reassess in an hour. Now, if they go down into 0 to 7, then you would just go back in there 2 hours after that. However, if it goes up to an 11 to 13, they need more Ativan. So you would end up giving 2 milligrams of Ativan and going back in there in another hour. If they were scored at a 14 to 16, they need more. So you go to 3 milligrams of Ativan. Still go back in there in an hour and assess them. But if you have a score of 17 or greater, and we'll see how easy that is to achieve, you give them 4 milligram dose of Ativan, and then you go back in there in 30 minutes. Because if your CIWA score is greater than 17 for more than 4 hours, you really want to contact the provider and see whether or not you can transfer that patient to critical care, because they may very well need a continuous infusion of that Ativan. Reassessment frequency, again, 0 to 7, go back in there every 2 hours. Now, do you do that forever? No. If the score remains below 7 for 4 consecutive assessments, you actually reduce the reassessments to every 4 hours. And then if you've been doing the assessments every 4 hours and they're still staying below 7, once it's 48 hours after their last drink, you really don't need to be using the CIWA-Ar assessment scoring tool. So 48 hours after their last drink, or you've done every 4 hours, you need to contact the provider, especially if they're staying 0 to 7. Remember, if they're 8 to 13, you're going to go back in there every hour. 14 to 16, you go back in there every hour. And then greater than 17, you want to be in there every 30 minutes. So you can see as your score increases, not only are you giving more medications, but you're going in there more frequently. And that becomes a pretty high acuity patient. So if your score is greater than 13 for 3 hours, even though you're giving the benzodiazepines, go ahead and contact the provider at that time. Don't wait till it gets to above 17. Adjunctive therapy. Now, you can't use these by themselves. You still need the benzodiazepines because they are the gold standard for treatment of alcohol withdrawal. However, there's this beautiful order set called the Delirium Power Plan. A lot of our providers forget this because we really don't use it that often. So Haldol or haloperidol is within the Delirium Power Plan, and that can be used for the agitation. Phenobarbital is a second option. Now, hypertension, we've seen that a lot of the excitatory aspects of the alcohol withdrawal will include systolic blood pressures. They might be above 180, or maybe even the diastolic blood pressure might be greater than 100. So part of the alcohol withdrawal protocol is some metoprolol or some clonidine if you're seeing that hypertension for your patient. How about severe withdrawal? Well, those patients need to be in critical care because dexmedetomidine has actually been studied and very successful with patients in critical care. However, we don't administer that in acute care. So that's only for severe withdrawal patients in critical care. So we have a case study practice now. And I want to see if you can go ahead and open up your packets, and you'll have one of the CIWA-Ar scoring tools. And this is going to be the tool that looks like this. And it's going to have you rating the nausea and the vomiting, the tremors, the paroxysmal sweats, the visual, auditory, tactile hallucinations, the orientation. So I want you to have this right by you so that you can go ahead and do this while we actually watch this this video, because you are going to score this patient.
Where is that bottle? Oh, I have something. No, I've seen that one already. That one's empty.
Ms. Drew? Hi, I'm Dr. Harding, and Nurse Ames told me that you might be having some alcohol withdrawal.
Oh, I'm sure he did.
So I'm here to do an assessment. Are you feeling nauseous at all?
Yeah, but I can't pick anything up. I feel so sick.
Okay. Can you hold your hands out for me like this and spread your fingers? Okay. And then can you show me, are you sweating at all?
Oh, I feel so hot.
Yeah. Can I see your palms? Okay, yeah, they feel pretty moist. Yeah.
It's so hot in here.
Do you feel anxious?
Yes, I feel anxious. Don't I look anxious, you silly cow?
You do look anxious. Okay.
Hurry up.
Okay. So are you feeling anything like pins and needles?
Oh, I'm itchy.
You're itching
just
or
itchy.
burning?
It's like
numbness?
No, just
Okay.
itchy.
And
Bugs,
how about
maybe
sound?
Sound.
Are
No,
sounds
it's
harsh?
Yes.
Okay.
Yes.
Are you hearing anything that isn't in the room right now?
What in the world does that mean?
Anything
You think I'm
that's
schizophrenic
disturbing?
or something?
No, it's just a standard part of the
No.
assessment. And how about the lights? Are the lights
are
too
really,
bright?
really bright. Can you
They're
turn
really
them
bright?
down?
Okay, can we turn down the lights? Thank you. Okay. And how about your head? Do you have a headache at all?
Yes, I have a headache.
And how would you rate it on a scale of 1 to 10?
I don't know. What's 10? I have no idea.
10 is the worst.
It's like a band. It really, really hurts.
Okay. Okay, and do you know where you are right now?
I'm in the hospital.
In what city?
San Francisco.
Yeah. And what's the date today?
I don't know. It's April.
April, do you know the
No.
year?
Yeah, 2012.
Okay. Okay. And Nurse Ames is going to come in and take your vital signs right
hurry.
now. Yeah.
Hi, Ms. Drew. My name is Nurse Ames. I'm going to take your vitals real quick. If you can just hang on a second. Hang on.
Hurry up. I hate having my blood pressure taken. Eat it. Oh, damn.
I know this is very uncomfortable.
Okay, we're going to slip this right under your tongue real quick. Careful and slow. Thank you.
Killed you right.
Hey, Dr. Hardy, we got a BP of 150 over 90, pulse of 110, respirations of about 20 to 22, and a temperature of 37.5.
Okay, we should start the protocol. So we're going to go over the assessment and come back and give you some medications to help
Yes,
you.
please, please. Oh, God, you guys just take forever doing everything.
Okay.
Hurry up.
Okay, I want you to take all of those scores and I want you to total them all up. So add them all together. What'd you get? So if you had a score of 0 to 7, which no one should have had, how about 8 to 10? Didn't have any of those either. However, once we start to get up there, I think a lot of y'all had scores that should be greater than 17. So on this situation, we're going to give this lady, let's say the doctor ordered some diazepam. You're going to give 4 milligrams of it in the route that the doctor orders. So you don't get to choose that. The doctor actually will order the drug and the route. And then when are you going to go back and assess that patient? Right, 30 minutes, exactly. Now, some of you might have gotten scores in the 80s, some of you got scores in the 60s, but essentially, does that make any difference, what you're seeing here? Everyone pretty much gets a score greater than 17, no matter what the variation in that score. So don't worry if you get a different score than the previous shift, because essentially, it's based upon what you're seeing on your assessment. And so you're going to give that dose and then go back, and the most important thing is reassess per protocol in either the 30 minutes, 1 hour, or 2 hours, and then you're going to get another score, basically to see how the medication that you gave was doing. Sound good? Here we have a second case scenario. Go ahead and take out your scoring tool, and you're going to do the same thing. You're going to score this patient.
Sorry to start with Ms. Cuervo. Hi, it's me, Nate again. I'm just checking up, making sure that you're okay. Are you hot?
Yeah. You open up a window or something?
Okay, I can't open the window, Ms. Cuervo. The windows are all sealed shut. I mean, looking at you, it doesn't look like you're sweating too much. Your palms do seem a bit wet.
Can you at least turn off the light? It's too bright in here anyways.
Sure. Turn off the light here. Would you like a cold towel?
No, it's not gonna help.
Okay.
There we go.
Okay, all right, well, I've come to just kind of do the same assessment that we did yesterday, so in case you need some more medication, I can give you some more medication, okay?
Yeah.
I'm gonna ask you a couple simple questions, so let's just start with, do you know where you are right now?
Hospital.
Hospital, okay. Do you know why you're here?
Something with my lungs, which I feel fine. Anyway, like, I can breathe normal
Let's
now.
keep that in your nose. Ms. Cuervo, yeah, you still need it to kind of help you breathe.
Really?
Okay. Do you know what the date is today?
I don't know. June 13th, 2019.
Okay, close. It's June 15th. Let's try this, okay? What's 1 plus 1
2,
plus 3
5,
plus 3?
8.
Excellent. Perfect. Any pain right now, Ms. Cuervo?
Yeah, the headache.
Do you feel pressure?
Yeah. Feels like pressure.
Okay. From a scale from 0 to 10, with 10 being the worst pain, where would you rank your pain?
1 or 2.
1 or 2. Okay. Do you need any medications right now for the headache? No. Okay. What about any nausea? Any nausea right now?
A little bit. Could open a window or get a breeze, that might help in here, but
Okay. Do you need anything for the nausea, or do you want to just kind of sit on it for now?
fine.
Okay. What about anxiety? You seem a bit restless, but any anxiety?
Yeah. Do feel anxious. I gotta get out of here. I got things to do after work.
Okay.
I have a gig tonight.
I know. Well, we're still kind of treating you for the infection in your lungs, so we're probably gonna miss that tonight. So we'll just kind of stay here for now until we finish getting all of our antibiotics. Okay. Last thing, let's just check this. Okay. Can you stretch out your arms like you did last time? Spread out your fingers for me. Excellent. It doesn't look like there's as much tremor as there was before. I do still feel a little bit of a tremor when I actually feel your arms. Any numbness or tingling anywhere?
Hands a little bit.
Any itching?
It's like pins and needles.
So no itching. Okay. Okay. Well, I'm just gonna go step out for a minute. Okay. I'm just gonna see if I can get you some more medication. That should help with some of these other symptoms that you might be having. And then after I give that to you, we'll touch base and see where you're at from there. Okay.
Yeah.
Okay. Excellent.
Okay, so you're going to go ahead and score this patient, and you're going to find out whether or not their scores are higher or lower than our previous patient. Once you've taken a look at all of this and you've totaled up all of your scores, is your patient greater than 17? Now they have a very different presentation. Definitely not as much moving, agitation, definitely different than our first patient. However, she is greater than 17. And so again, you're gonna deliver 4 milligrams of lorazepam in the ordered dose, and you're gonna go back in there in 30 minutes. So as you can see, really what you're gonna be giving to these patients is determined upon your physical assessment. And you're not gonna be doing this forever. The great news about it is that you can discontinue this protocol when it's been more than 48 hours since the last drink. If the CIWA score over the last 24 hours is less than 7, or it's been greater than 8 with just intermittent doses of benzodiazepines. You call the provider and they're going to look at those CIWA scores from the last 24 hours, and they'll initiate a taper based on those benzodiazepines if we've had to give it to them. If it's been less than 7 and we haven't had to give them anything, then the provider will actually discontinue the alcohol withdrawal protocol, which means you also discontinue the CIWA-Ar assessments. So this is a 48-hour protocol that we typically use unless the patient needs it a little bit longer. And just think of it as a electrolyte replacement protocol. Just like you would treat any patient with an electrolyte depletion with a supplement, it's exactly what you're doing with the alcohol replacement protocol. So again, my name is Monica Tennant. Very pleased to have talked about the CIWA-Ar protocol with you today. And I hope that if you have any questions, you'll reach out to me. Thank you so much.